Welcome, everybody, to this webinar on the Canadian Guideline on Concussion in Sport, second edition, recommendations and resources for preventing, recognizing, and managing concussions. Parachute and Cirque are pleased to provide this opportunity for the sport, education, and health communities to hear about the latest updates for concussion best practice. My name is Stephanie Cowle, and I'm the Director of Knowledge Translation and lead for concussion initiatives at Parachute, Canada's national charity dedicated to injury prevention. Today, I join you from the traditional territory of the Wendat, the Anishinaabeg, the Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. Today, this land is still the home to many Indigenous peoples, and we are grateful to have the opportunity to live and work on this land. And while we meet today, gather on a virtual platform, I invite you all to take a moment to acknowledge the importance of the lands which we each call home. The goals for today's webinar are to help you understand changes to recommendations for concussion best practice, particularly as they've been applied in Canada. We'll also highlight for you available resources that you can access to help with your work in concussion, no matter what that is: policies, protocols, education, awareness, supporting others. And we'll make sure that you understand where to find these resources. We also want to provide this opportunity for you to be able to consider how you can use this information and the resources in your setting. At the end of the session today, we will have time for question and answer. Please, at any point, feel free to put your questions in the Q&A box. You don't need to hold them till the end. If there are any questions that we don't get to today, we will send out responses to those unanswered questions, as well as links to documents and resources after the webinar. This session is being recorded, and the link to the recording, when it's ready, will be sent to all registrants. And finally, at the end of the session, when you go to leave Zoom, you will be prompted to fill a very, very short evaluation survey. And we really appreciate you taking just 30 seconds to a minute to answer the questions. It helps us understand that these sessions are effective, that we're achieving our goals, and to be able to report back on the work that we've done and the success that we've had. So thank you in advance for taking the time to do that. I promise it's just a couple of questions. We want to express our gratitude to the Public Health Agency of Canada. Their support has enabled us to do this work, including updating the Canadian Guideline and providing sessions like this webinar today. As quick background, the Canadian Guideline on Concussion in Sport was first published in 2017. And we have now updated the guideline, presenting the second edition in March of 2024. And this guideline was developed to help build a foundation for a harmonized pan-Canadian approach to concussion, started under the mandates of the Federal Ministers of Health and Sport. The guideline provides recommendations in 7 areas, going from pre-season education through an incident recognition, management, all the way through to complete return to sport, school, and other activities. For the new updates to the guideline in 2024, there were in particular 3 sources that helped with this work. The first being the 6th International Consensus Statement on Concussion in Sport that was published in June 2023, based on the Consensus Conference held in October 2022. In addition to the Consensus Statement itself, there are 10 systematic reviews answering various questions about concussion published along with the statement. And these are excellent sources of the status of high-quality evidence for concussion internationally. We're also very fortunate in Canada that we have incredible experts and expertise. And one example of that are the clinical practice guidelines we have in Canada. There are guidelines for pediatric care up to the age of 18 and adult concussion care. And we have worked closely with the leads of these guidelines. They have amazing expert panels that have helped them keep their recommendations up to date. And it was a really important priority to ensure that the guideline on sport aligns with the clinical practice guidelines so that we are communicating consistent recommendations to all communities, including both health and sport. So we really appreciate the work of those guideline groups and their collaboration in all that we do in this area. I'm going to dive right into talking both about new additions to the guideline and then going through areas that have been updated with updated recommendations, and also point out some areas that really haven't changed at all. One of the new things added to the guideline in the 2024 second edition is a distinct section on concussion prevention. This, of course, is an important priority where there are opportunities with concussion, not just for primary prevention, which is preventing concussions from happening in the first place, but also important opportunities for secondary and tertiary prevention. We know that when concussions are recognized, when people get appropriate care and timely care, and concussions are managed properly, that people have better outcomes. It's shown in the research. So secondary prevention, that recognition, response, and getting people to care is really, really important for this injury. And also tertiary prevention, looking at how we can reduce or prevent long-term complications from concussion, including considerations for when a person might have to make a difficult decision to no longer participate in riskier contact sports. This area of the guideline presents considerations for organizations on considering prevention in their setting for their activities. I want to speak to a few key points about primary prevention. So that's preventing concussions from happening in the first place. And one of the things that we emphasize in this section of the guideline is that prevention should be considered from multiple perspectives. We can look at changes to the participation environment, to equipment that's being used, how training and skill progression are implemented in the sport, various rules and policies, as well as how those are enforced. And then also take a look at the sport and organizational cultures and whether any shifts need to take place. And this is really important to look at these different perspectives and not have a narrow view of prevention where people might automatically turn to, oh, we need helmets, oh, we need one particular thing. There's not necessarily one specific answer, but it's looking at the setting and looking at all the potential opportunities to intervene. And that's really important to the practice of injury prevention. What we also emphasize is that prevention be data-driven and that interventions be evaluated. And so what this means is looking at and understanding how concussions are occurring in your setting. And in the guideline, we provide some considerations, some questions to ask about concussion to start to have an understanding of how the injuries occur, because that will pinpoint where we can potentially intervene. And then evaluation can help us understand whether those interventions are having an impact, whether they're having unintended consequences, and whether adjustments need to be made. So really encouraging people to think about prevention and thinking about it in a very strategic way. And we're seeing more and more examples of this, of collaboration between sport organizations, researchers, clinicians, to try to understand concussion in their setting and try out new things. And finally, on the point of primary prevention, we do highlight in the guideline strategies that have been shown to be effective for preventing or reducing risk of concussion. And this is largely based on the most recent systematic review of concussion prevention that was published with the consensus statement by Paul Eliasson from University of Calgary and colleagues. And the interventions that are shown to be effective include policies disallowing body checking in youth ice hockey, strategies to limit contact practice in adolescent football. And this is both the frequency of contact practice as well as the duration of contact practices, the use of mouth guards in adolescent ice hockey, and neuromuscular training warm-up programs in male rugby players. And you'll notice here that there's specific information about the population and the sport where these interventions were studied. And so that's an important consideration where we have evidence in specific areas. We need more evidence to understand how these interventions might translate to other populations and to other activities. But they may give you a starting point of intervention for your sport, especially if there's similarities with activities you do in your sport or the mechanisms of injury. These could potentially open up opportunities to explore more. The other new addition to the second edition of the guideline is a note about considerations for athletes with disabilities. And we have to recognize that there are significant gaps in the evidence and in guidance for assessment and management of athletes with disabilities, including understanding and hearing the voices of their experience. And so there are gaps in the research and also in the common assessment tools that are used for concussion are not validated for use with individuals with disabilities. And a lot of this information has been captured in the first position statement of the Concussion in Parasport group. And we'll include with the follow-up from this webinar a link to this statement that really highlights the state of information and important considerations for concussion in athletes with disabilities. This is an area that we hope will continue to grow in attention, particularly in the evidence and in building guidance. And I'm excited to share that there are many initiatives happening in Canada to target this type of work. Work with organizations such as Special Olympics Canada, Canadian Blind Sports Association, Cerebral Palsy Sports. They are working together with clinicians and researchers to really examine considerations for their athletes, their networks, and that can benefit everyone really. So for the rest of the explanation of the updates to the guideline, I'm going to walk through the different areas of recommendation. So those 7 areas that I mentioned, I'm going to go through each and highlight where there are and aren't changes. So the areas of recommendation start with preseason education, and there are no changes to recommendations for this area, but I will highlight that the tool we provide for this area, the sample preseason education sheet, has been updated to reflect updated information. So if you have concussion education materials, if you've made use of this education sheet template before, you'll want to check out the new version and compare and see if there's any updates for you to make to your own version or use the updated one we provide. The next part of the guideline is after an impact occurs with head injury recognition. And there are no changes here to the recommendations around recognizing and removing a person from play or activity. We have in the guideline, however, developed what we believe is a little clearer language on how we explain when to suspect concussion, to highlight red flag symptoms, and also to explain what happens in the case of maybe there's no symptoms right away and watching for delayed symptoms to arise. So a little change in the language that we hope will be clearer, and you may want to check that out and see if that's language that you would like to make use of. There is an updated tool for concussion recognition, and that is the Concussion Recognition Tool 6, which replaces the Concussion Recognition Tool 5. It looks visually quite different. I'm actually really excited about the updated design. I think it's really improved and really legible. But in terms of the content, there's not a lot of significant change. There's some wording change to help with better explanation and understanding. And there's some slight adjustment to change the language from memory questions to orientation questions. So fairly subtle changes in the CRT6 in terms of content, but continues to be the most up-to-date tool that absolutely anyone can use to help recognize a concussion. And it still rings true for those of us that are not healthcare professionals when it comes to recognizing a concussion. Just one sign or symptom after an impact is enough to suspect a concussion and take the next steps. Next, if an athlete or a participant is removed due to suspected concussion, the next points are around perhaps sideline medical assessment if healthcare professionals are on site, and followed by in-office medical assessment with a medical doctor or nurse practitioner. And again, there are no changes to these recommendations. What we have added in the guideline is some additional information around medical assessment of how scope of practice can vary by province and territory, and giving some of those examples. So one example would be that while we recommend that a medical doctor or nurse practitioner conduct a medical assessment and provide the clinical diagnosis of concussion, in Quebec, a nurse practitioner is not licensed to provide that diagnosis. So it would be different in the province of Quebec. And that's just one example. So we give a few of those in the document. Again, if that's relevant to you, if you're working across the country, that may be information that you'd like to be aware of. Again, here, the Concussion in Sport group has updated the tools that they provide for assessment, particularly for sideline assessment, with the updated sport concussion assessment tools, both the child version, which is for ages 8 to 12, and the non-child version, I guess, just the SCAT, that is for ages 13 and up. And for those where, if this is relevant to you, just note a subtle change in the child SCAT 6. It used to, the child SCAT 5 is described as being for ages 5 to 12. And this one, it's changed to for the ages of 8 to 12. So a slight change in the age range for whom this tool is recommended to be used. Unlike the CRT, these tools are to be used by health professionals who have training to use them. For medical assessment, along with the guideline, we also provide a sample medical assessment letter template, and that similarly has been updated. So again, if you use that template or you have one of your own, check out the updated version and make any adaptations that you need to. Now we'll move into management of a diagnosed concussion, and here is where we start to see changes in the recommendations that we really want you to be aware of. The first piece is around return to school after concussion. And I'm going to show you on the screen a little side-by-side of the old version to new, and then I'll show you the newer version in a bit more detail. So updates to the steps for return to school allow students the opportunity to start returning to school earlier if it's appropriate for them. So in the past, for stages 1 and 2, it was very prescriptive that these stages happen at home. In the updated version, at stage 2, there is an opportunity for a student to start returning to school if that works for them. This is not meant to force or rush kids back to school, but what we don't want to do is keep kids out of school unnecessarily. So it's really about providing a little more nuance for the individuals and not wanting to hold children back unnecessarily, because the benefits of children returning to school, returning to their peers, their social environments, are very positive, particularly for their mental health, and are not shown to harm their recovery. And based on the recommendations of the pediatric living guidelines, we've included the recommendation that children and youth not miss more than 1 week of school in general. And that's talking about complete absence from school. So not going to school at all, even for partial days or testing out different variations with adaptations. Children generally speaking, should not be kept at home and completely out of school for more than a week. Another updated recommendation in this area is that there's a bit more clarity around screen time and showing that in the first 24 to 48 hours, screen time should be minimized. After that, there can be gradual resumption. It's really going to depend on the individual's reaction to screen time, how it affects their symptoms, how it makes them feel, but a little clearer that in the first 24 to 48 hours, we do see a positive impact from minimizing screen time there. So what do these more detailed steps look like? The first step of return to school is the first 24 to 48 hours. And this is where the child or the student can do daily activities at home that don't really exacerbate their symptoms. And these are activities of daily living. So preparing meals, whatever you need to do for hygiene, moving around the home, talking to your family, perhaps a little bit of talking with friends, just keeping some of that daily routine going. And we really want to emphasize the social piece, which is so important for everyone, for youth, for older adults, for all of us. Maintaining social ties is really important. And step one should only be a maximum of 24 to 48 hours. Then the person should progress to step two. At step two, the person can begin with more cognitive activities, and this can start to take place at school if it's appropriate for the person, or they can do this at home. So the option is there, or a blend of both. And at this point, the person is starting to build more cognitive work, cognitive load, and so may need to take lots of breaks, adapt activities, and just start gradually resuming. And again, just that importance of continuing connections socially with peers. The third stage will be reintroducing schoolwork. We really do want to see young people back at school, at least for part-time hours at this point. And they're building their tolerance not just to the schoolwork, but also all of the things that are around them in the school environment. So the sights, the sounds, the smells, the people, all of that, in addition to the schoolwork itself, is quite demanding on the brain. So at this point, a lot of students will require some sort of accommodations to assist with being able to tolerate that environment. And that can include accommodations to their workload, but also to their space. Can they be allowed to wear sunglasses or a hat in class to help with light? Can they be provided a quiet place to eat lunch, maybe with one or two friends? So again, they're not isolated. There's all sorts of ways to think about accommodating an individual returning to school from concussion, so we can really help them continue to be integrated in that space. And finally, when a student is able to progress to their full workload, accommodations that are specific to the concussion injury can be removed. When they get to that point of full day, full load, and no accommodations for the concussion injury, that's when return to school after concussion is considered complete. And what about return to sport? So similarly, there's updates to steps and a little bit earlier access to certain types of activities. And so there's really encouraging evidence that as people are returning from concussion, there are things they can do a little bit earlier that are beneficial for their recovery, and on the flip side, do not harm their recovery. In the past, before, the recommendation was that there would be a 24 to 48 hour rest period before starting step one of return to sport. In the update, that pre-rest period is gone. And so step one is the first 24 to 48 hours, and it matches exactly that step 1, 24 to 48 hours of the return to school stages. So return to school, return to sport, step 1 is the exact same and starts at the same time. It's that first 24 to 48 hours after the injury. In the updated recommendations for return to sport, there is earlier introduction of light, increasing to moderate aerobic exercise. There's also earlier introduction of resistance training. In the previous version, this was initiated at step 4, and now this is allowed for at step 2, so long as it doesn't really exacerbate symptoms. The most significant change in return to sport stages is the timing of medical clearance. And this is going to have the most impact in terms of ensuring that your processes and protocols and communications are changed to match these recommendations so that everyone's on the same page. The timing of medical clearance used to be before step 5 of the return to sport, and now is recommended to be before step 4, which is a little earlier. And the intent of this move is really to create a bit more time and space for the person to recover before being exposed to significant risk of inadvertent head contact. So in addition to keeping the person away from intentional contact practice before they're healed, this is also an effort to reduce the risk before that, reduce their exposure to inadvertent head contacts. Now, this is not an absolute elimination of risk of inadvertent head contact. That would be impossible. It's just not possible to absolutely eliminate that. For example, you could slip and fall on ice. There's so many ways that a potential impact could happen. But what we're talking about is creating a low risk environment, looking at what we can control and modify to reduce the risk of inadvertent head contact while the person is increasing their tolerance to activity and extending themselves more and more to ensure that they are recovered to the point where they have no symptoms while fully exercising. So an example, you might think about this in your setting. It's really going to vary depending on what that participation setting looks like. But if we think about schools and participation, for example, a school gym, there's a lot going on. Teachers and coaches have many students to just one supervisor. And so it is really challenging to control equipment, balls, bouncing, flying around, and what every single student is doing. So that's a case where we can consider, okay, returning the child to that environment before they're recovered is not a great idea. So how can we support the reintegration of activity for them without placing them in that environment where there's so much risk of head contact while they're still recovering? So thinking about it in those kind of terms. Again, that quick side-by-side just to highlight where the change happens. Here we see at stage 2, no resistance training in the 2017 version. And in 2024, we see the opportunity to begin resistance training if that's appropriate. And again, we see the change in the timing of medical clearance. So before step 4, rather than before step 5. And with step 3, you see that mention of inadvertent head impact. The version of the return to sport table in the guideline itself is more detailed in what each of these stages look like. But just to quickly review, you have that first stage, that 24 to 48 hours, same as return to school. So opportunity to minimize screen time, daily activities around the home, maintaining levels of social interaction at this point, and that first stage only lasting 24 to 48 hours. As we progress through the return to sport steps, similar to before, each step should take a minimum of 24 hours. It may take longer for folks at any particular stage, and people may experience symptom worsening to a point where they need to keep trying before they're ready to progress to another stage. So at stage 2, we see that introduction of light aerobic exercise and building up to moderate aerobic exercise. In this technical document, we refer to heart rates, but in our concussion guides, we talk more about what light and moderate aerobic exercise look like for the average person who's not taking heart rates. So when we're talking about moderate aerobic exercise, we're talking about an activity where your heart may be beating faster, you may be breathing faster, but you would still be able to carry on a conversation while you're moving. You're not so out of breath that you couldn't have a conversation at that point. So that's a bit of a description of what we mean when we talk about moderate exercise, moderate aerobic exercise. And that third stage is really continuing to progress the individual, increasing the intensity of the work that they're doing, really testing out that increased load and how it might impact their symptoms or not. And we want them to progress to the point where they are symptom-free while fully exercising, but doing this in a lower risk environment for as much as we can control. At this point, then, there would be consideration of medical clearance. And at this point for medical clearance, if they are a student, they should have returned fully to school by now. That's the priority, is that they're returned to school fully. They have completed these first 3 steps of return to sport, are symptom-free at rest, as well as while they are fully exercising in a low-risk environment, and then medical clearance can be considered. After this, it's progression through, again, taking away that idea of we're going to control for inadvertent head impact and just introduce training still in non-contact. So we don't want intentional contact at stage 4, but we're less concerned about inadvertent head contact, and then progressing through full practice training, non-competitive activities, full participation in physical education class, and then return to sport. Through all these points, the person should remain symptom-free. And so if symptoms return at any point, the person should be reevaluated. And so once they're cleared, it doesn't mean that, okay, the concussion never happened, we never have to see our healthcare provider again. It really is through these stages, you'll note that we really have to ensure that they continue to tolerate activity without symptom return. If there is symptom return, they do need follow-up care and figure out a way forward. So these are guidelines, and it's really important that we recognize that at the end of the day, the individual's healthcare provider will provide them with advice for their particular case. And so that may vary from what these steps look like. And that's okay. It's going to be a very individual thing, but these offer a guideline for most people. Another thing to point out about the progression through return to activities is the way that we talk about symptom exacerbation, or talk about symptoms getting worse during the return to activities. So previous guidance in 2017 said that as people are returning to activities, as people progress to a stage, they should have absolutely no worsening of symptoms. No new symptoms should appear, and the symptoms that they do have should not get worse. And what we have now is a better understanding that it's actually quite common as people are starting to return to activities and increase their progression through activities, their symptoms might feel worse. And there's a bit of a threshold for that's okay. The brain and the body are doing what they need to do. We need to challenge the brain and the body to a certain extent as we're recovering. However, there's a point when it goes too far. So we're not saying, well, you know, if you feel absolutely horrible, your head is pounding and you can't continue, then that's fine, that's natural. So it's a balance between these things. And so the new recognition, it's common, it's acceptable, it doesn't harm recovery if people's symptoms worsen slightly with activity. And individuals can continue progressing through activities and through the steps if they have mild and brief symptom exacerbation. And that's the language that's being used, mild and brief. How do we define that? So mild symptoms are defined as, as someone's doing an activity or after someone does an activity, because sometimes symptoms worsen later on. The symptoms that they're experiencing should worsen no more than 2 points on a 10-point scale. So if I say today, oh, my headache's kind of a 5 today, and I did a little bit, and I did this, particular activity, and now it's feeling like at a 6 or a 7, that's okay. That's within an acceptable range. But if someone's like, oh, my head is now at a 9, it's just absolutely pounding, that's a sign that it's too much. In terms of brief symptoms, with that symptom worsening, we want to see it come back down to how they were before the activity within an hour. We don't want the symptom worsening to last more than that. So these are guidelines to think about. At the end of the day, it's that there could be a little bit of symptom worsening, but it shouldn't last too long. It shouldn't be too much. And of course, if it's to a point where the person can't tolerate it, that's always going to be too much. And we need to pull back a little, take a rest, adapt activities, maybe try again the next day and figure out what we need to do. But you can see it leaves a little bit more room in the progression rather than saying symptoms worsen at all, stop, go back. So it's a change in how we progress through steps. The next section in the guideline is about interdisciplinary concussion care. And this is really for the cases where symptoms are persisting. They're lasting longer than is typical. And those are the cases where we want to identify that a person may be at risk of that or maybe experiencing that. And that's where people need more specialized help. Typically, a person will recover within 4 weeks with proper management, pacing, progressing through those return to school, work, and sports steps. But a percentage of people will have persisting symptoms and they will need more specialized care, or they'll probably do better if they get more specialized care. So overall, there's no changes to our recommendations in this section, but we do want to highlight that now typical recovery is defined as up to 4 weeks for everyone. Previously, we made a differentiation between children and adults, saying for adults, typical recovery was up to 2 weeks, and for children, it was up to 4 weeks. Now the understanding is that typical recovery is up to 4 weeks for everyone. We don't need to distinguish by age. So again, this may be language that you have in policies or protocols or resources or education tools where we talk about typical recovery. We want it just to say that typical recovery is 4 weeks for any age group. In this section, we've also added links out to the clinical practice guidelines, the pediatric and adult guidelines that I mentioned earlier, because really when it comes to managing symptoms, especially persisting symptoms, that care should really follow the clinical guidelines. And so that's where we refer out to that expertise. And the final step in the recommendations of the guideline is that full return to sport. And really what's changed here is just the way timing of consideration for medical clearance is described in this section, which we've already talked about. It matches the updated return to sport stages with that medical clearance before step 4. We also have updated our sample medical clearance letter. It contains those updated steps, those updated steps 4, 5, and 6. So again, if this is a template that you use, or if you have a sample letter that you use within your organization, you may want to check this out to see if you need to make some updates or use this updated version. You likely won't be able to read this. That's okay. It's really just for illustrative purposes to let you know that just as before, the end of the guideline wraps up with a summary of the pathway that follows the recommendations of the guideline. And we have updated this pathway as well. There are some very minor differences in the pathway. So in the pathway, we refer to the step of what's happening, who is involved at this step or who is taking the lead at this step, and then what tools are available for this step. So where there are updates to, for example, the concussion recognition tool and the sport concussion assessment tool, we've updated those to the 6th version rather than the 5th. Pretty simple logical change. And the other thing that's updated in the pathway is that when talking about the option for interdisciplinary concussion care, we have an asterisk defining what persisting symptoms are. And again, we've updated that definition to typical recovery being up to 4 weeks for everyone. Again, removing that distinction between children and adult recovery times. So those changes have been incorporated in the pathway. We do have an editable version of this pathway that we can provide as a template if it's something that you are looking to use and perhaps adapt with your organizational colors, language, what you need. So if that is something that that you would like to make use of, you can reach out to me. I'll provide my email address in the follow-up email, in the follow-up communication. And I can provide you that editable version in both English and French. So that's a summary of the additions, changes, and where there's no changes in the Canadian Guideline. And before we open up to questions, I want to highlight some of the wonderful resources that are available. All of the resources that we'll be sharing are available in both official languages, and that includes the guideline. So at parachute.ca/guideline, which is the shortest way to get to this, that is the page where you will find the updated version of the guideline on concussion in sport. And there are tools directly associated with it to help people or organizations establish or update their concussion protocols and policies and implement them. So we have an updated template for a concussion protocol. We also have a protocol checklist if you have an existing concussion protocol that you just want to check if you align with the harmonized recommendations. We have those medical letter templates, the preseason education sheet templates, and we also provide links out to all of the tools that are not Parachute owned. So again, the concussion recognition tool and sport concussion assessment tool that, depending on your setting, may be used. I'm also happy to share that Parachute has updated all of our concussion guides for various audiences. You can find these at parachute.ca/concussion or /commotion cerebrale. There are guides for parents and caregivers, coaches and trainers, athletes, teachers. We are updating our guide for physicians, which will eventually be available. We also have our return to activity sheets for return to school, work, and sport. So all of these are free to download and use in both official languages. If you're interested in using this information to adapt or create your own resources, please reach out. We're happy to have the information used just with credit to Parachute. And the goal at the end of the day is to reach people with good information. So if there are other ways to do that, we're happy to collaborate. Also want to point to our partners at CIRC, the Sport Information Resource Center, and they have an excellent collection of concussion in sport resources, everything from communication and media tools to links to organizations that are doing great works, blog posts about what various organizations are doing, information about cutting edge Canadian research, all sorts of great information. They also, for the past several years, have hosted an annual Concussion in Sport Symposium, and the video recordings of the presentations from the most recent symposium, which happened in January 2024, are available. So if you're interested in learning more, check out those videos to see great content from sport, but also health, education, and athlete voice. One of the resources we collaborated with CIRC on as well is an information guide to help sport organizations develop their concussion policies. And the reason that we developed this is Sport Canada has certain expectations, particularly for national sport organizations, to have certain elements included in their concussion policy that complements their concussion protocol. So if this is relevant to your organization, check out that resource. And also it's something that Parachute is happy to work with organizations on. You may be familiar with the concussion awareness training tool, the CAT. online. And again, all of the courses that they offer are free and are available in both official languages, and they target various audiences. We really value these evidence-based courses. There are some new additions. If you haven't checked CAT out in a while, there are new youth and athlete courses that are focused, one on high school aged youth and one focused more on university varsity athletes. And there's also, great information, updated information for medical professionals and those working with women who survive intimate partner violence. So a really wide range of information. The resources on the CAT website are updated, and the updated versions of the course modules are being released very soon. So watch out for those. And finally, another updated course that's going to be available soon is the Coaching Association of Canada's NCCP Making Headway in Sport course. It is designed and built for coaches, but I have to say it certainly could be valuable for anyone who may be in a position for decision-making about perhaps recognizing a concussion and perhaps needing to remove a participant from activities. It has lots of great information and really considers those real world scenarios where you have participants who don't want to leave the game or practice, parents who want to see their child stay in, and how do you handle some of those difficult scenarios? So they are currently implementing the changes, and that will be available again in both official languages very soon. And it's free for anyone to take. You don't have to necessarily be a coach. You just have to sign up for a free account. So finally, just some thoughts as you take this information away. What might it mean for your work or your organization? Of course, this is going to depend on your role. But if your organization has a concussion policy or protocol, now is the time to start working on updating it. Again, we have those tools on the website that provide the templates. I will send out, following the webinar as well, we have a guide to updating your protocol if you already have a harmonized protocol. So if you have a protocol that matched the Canadian Guideline on Concussion in Sport from 2017, we have a guide that walks you through your protocol and explains what language to change. So I'll share that out after this session. You may want to also look at what tools and resources do you use for implementing processes and policies at your organization or in your setting? Do you have assessment and clearance letters? Do you have communication tools for tracking progression through return to sport or school? If so, those should be updated to match the updated steps and recommendations. Download that new CRT6. Again, it's free. Start using that updated version rather than the 5th versions. The French language version of these tools is being worked on by amazing colleagues we have here in Canada, and we hope to make that available as soon as possible. Take a look at any educational resources you use, communications. Do you have information on your website? Let's make sure that that's up to date. If you link out to resources, you can link out to Parachute's new ones. If you already link to our guides, we have kept the links exactly the same. So if you link to the Parachute website, those should automatically go to the new versions, but take a look and just check that that's set up to make sure that's the case for you. As you're making changes to information and resources, and especially if there's changes to processes, you will need to communicate those changes out to others in your organization. So really educating others on the changes and making sure everyone's on the same page. This is a period of transition. It's going to take some time for all organizations to adjust to the changes, but communication will start getting us there. And finally, as I showed you, there are resources available. There's free trainings and education. So really encouraging folks, even if they've done this before, let them know that there's new information, there's new approaches. And so they can take quick and easy education to update their own knowledge and be on track. I want to thank you so much for listening to these updates, and I will, as I said, in the follow-up message, I will make sure that you have my contact information and links to any resources mentioned in this presentation. And for now, we have about 10 minutes to address any questions. So please feel free to continue entering your questions in the Q&A box. And I see that we have a few already. So there is a question about sharing the slides with you. We certainly can share a version of this deck. Happy to send that out, as well as links to important content that we want to call out. For example, link to that parasport statement. And we'll follow also with the link to the webinar recording. So thanks very much for that question. Is the information available on our website? And as a sport administrator, can you add these resources to your website? Absolutely. So as it did come to the end of the presentation, we talked about where these resources are. So if you visit the Parachute website and access these resources, absolutely, you can link to them on your own website. You can share them out. As I said, we just want to get the information out there. So please feel free to use them as you need. There are, for sport administrators in particular, there's some additional information on our website talking about some of the challenges with protocol implementation that we heard from sport organizations, and worked with the University of Calgary to develop some additional resources. So things like a communication sheet for return to sport, some ideas around how to make concussion education more of a priority in your organization if you're having challenges with that, some things like that. So you can check out, there's all the resources mentioned here and a bit more on the website for sport organizations, for schools, and for others. We also, in this presentation, aren't focused really on the clinical care side of things. Again, that's really the expertise of the clinical practice guidelines. But we do have a collection on our website of resources for health professionals that will help direct you to, for example, how to find those clinical guidelines, how to find the CAT training for medical professionals which is accredited, things like that. So we try to guide you to resources that are specific to the work that you do and most relevant to you. There is a question about typical concussion recovery and whether the recovery time of 4 weeks, if that's for sport concussion only or for any concussion. This recovery period really is based on the research in sport concussion. So really, I would say it's targeted to that, or it's based on the evidence for that, may not necessarily translate to recovery period for concussion from other causes. I have also heard, broadly speaking, beyond sport, people speak more about recovery taking more like a couple of months, perhaps with other mechanisms. So I don't want to speculate too much on that, but I will say that this is based on evidence pulled from the literature about concussion in sport. So we know it's true for that case. It raises a really important point, though, that concussions happen in all sorts of activities. Falls are actually the leading cause of concussion in Canada, and particularly for young children and older adults. So these are also areas that need addressing, certainly beyond just the sport realm. Okay, there's a question. Are there any specific guidelines for psychologists working with individuals recovering from concussion, particularly with eye movement-based therapies such as EMDR or ART? So for this one, I would say that I'm not in a position to answer that question. Thank you so much for asking it. And I would defer you to the clinical practice guidelines and the folks for that. So I could reach out to you and connect you with folks if that's something that you would be interested in. I can let you know who to chat with. Certainly they look at practice recommendations, especially for symptom management with lots of different professionals, including psychologists, allied health professionals, and the like. So if there are recommendations at this point, if there's evidence to point to recommendations for that, those would be the people who can help you out. So I will, I'll send an email with more information to you. Okay, great. And then let's see. I had watched an interview with Dr. Alan Sills, who is the Chief Medical Officer for NFL and also a neurosurgeon. He was asked about mouth guards preventing concussions, and he said that they don't affect the rate of concussion according to the data. Great for preventing dental trauma, but do not do a lot for protecting concussions. Was something that surprised me. Just wondering if you had any comments on that. Thank you very much. Yeah, mouth guards come up a lot. And over the years, there's been a mix of evidence. And so that's why it's been tough for folks to really make strong recommendations or connections between mouth guards and concussion. There's been studies showing they are effective, studies showing there aren't. And then there's also, what's the quality of those studies? More recent work is showing more so that there is a reduction in concussion, or a risk of concussion, I should say, with mouth guards. And I can, in the follow-up, I can share out what that exact information is. I can share some links to that updated information. But in the most recent systematic review of prevention related to the consensus conference, and that work again being really led by Dr. Paul Eliason and Dr. Carolyn Emery at University of Calgary, are really finding more data to support that there is a certain level of risk reduction. Are they going to absolutely prevent concussion? Not necessarily, but there may be some benefit. And so for the reasons that you stated, they're very valuable and important for preventing dental trauma, which is important. Dental trauma is quite devastating. And so that in and of itself is a great support for mouth guards. We don't want to overstate the use of mouth guards for concussions, saying they will prevent all concussions. However, the body of evidence building over time is starting to show some more positive effects of mouth guards. So that's kind of where we're at this current stage. So I hope that's helpful. But as I said, I'm happy to share out a couple links to what information is available. It's certainly, as I said, been back and forth topic over the years, as is the case with science. Various studies have to be done in order to build up that body to give us better evidence to make decisions from. Okay. I'm not seeing any more questions roll in. I really appreciate your attention, appreciate those who have added questions. Oh, I see. Sorry. As always, I see that and one more pops up. So this will be the last question, just so that we can wrap up on time. Question is, how coordinated are provincial, national, and international protocols and policies? For example, would different national sport organizations have different statements or follow different protocols? Great question. And improving that coordination, improving what we call harmonization, is the goal of the work we've been doing since 2016, is to, the reason we use the word harmonization is things may not be identical. There is opportunity to take into account some differences. For example, there are differences between martial arts versus water sports versus lawn bowling. There's various differences in those activities. However, when it comes to concussion management, the principles at the heart of it should be the same. And so with our previous version of our guideline, we worked with more than 50 national sport organizations to have concussion protocols that are harmonized with the recommendations from the guideline. Now, we have to admit that at other levels, it becomes a little bit more challenging. And the landscape looks different everywhere. There's not a natural flow from national down to grassroots level, unfortunately. So that's where there's collaboration with provincial and territorial partners. In some cases, national sport organizations have have strong relationships with their provincial or local bodies. In some cases, it may not be the case. So there's lots of effort in trying to expand it to the provincial, territorial, and then community levels. But I will say that the grassroots level has been the biggest challenge that we continue to work on. We really are working to ensure alignment with the information available in Ontario through Rowan's Law. We were involved in creating the Rowan's Law materials because we wanted to ensure that level of harmonization. And we work with various partners. So another Ontario example is working with OFIA to update their concussion protocols for schools. International level, it varies. There have been international bodies that have actually looked to what we've done in Canada and used Canada's and Parachute's concussion protocols. There are international bodies that actually don't match updated recommendations, and that's been a significant challenge. So I would say yes and no, and a whole lot of mess, but it takes effort to coordinate, and there are many, many people involved in that. So we really, really do want to see that harmonized approach across the country, and sharing this information, making it freely available, is one of the ways we are hoping to do that. Thank you all again so much for joining. Thank you for your questions. We'll send out follow-up information, and I'm really happy to answer any follow-up questions you have or work with you on any efforts that you're doing in this area. Please take a sec to answer the evaluation questions on the way out, and hope you have a wonderful day.